epidemiology of malignant neoplasms in young children in the Kyrgyz Republic. Makimbetov Emil Kojashevich, Talgat Talantulu. Kyrgyz Russian Slavic University, Bishkek, Kyrgyzstan. Osh Regional Children's Hospital, Osh, Kyrgyzstan. Introductions every year about 400,000 children are registered worldwide in the newly diagnosed malignant neoplasm in children. In recent years, in recent malignant tumors in children, such a significant increase in survival rates and subsequently a decrease in mortality rates in the developed world is most likely due to improved diagnostic and treatment methods science, which was facultated by the concentration of pediatric cancer patients in pediatric cancer centers. In low and middle income countries, area of children live, the children diagnosed with mean each year have limited access to treatment and only about survival. The difference in survival rates between children with in high income and low income countries continuations to within as treatments are developed in the former but not implemented in the latter. Actuality cancer occurring in younger children often have clinical and biological features compared to the some histologic variants in older children. The distribution of cancer by histologic variant in infants and older children also differs. Chow Ping Yang et al. Reported cancer cases over a 10-year period in children under 5 years of age. The percentage distribution of the main types of the cancer was different in the infant and young child groups. Actuality, according to some literature data, cancer account for malignant tumors under 15 years of age. In infants under 1 year of age and young children 4 years of age. This leads to relatively high age standardized morbidity rates at an early age. Researchers have also shown that 3 is a slow but steady increase in the incidence of malignant neoplasms in children worldwide, including in younger age groups. For example, the annual increase in the incidence of all types of tumors ranges from with a higher incidence in girls than in boys, a statistically significance in increase was observed for epithelial tumors, melanoma, and brain tumors. Many aspects, etiology, and pathogenesis of cancer in the children are currently unclear. There is significant racial, geographic, and gender-related variability in the distribution of tumors in children. There are certain difficulties in the diagnosis and treatment of tumors in young children. Most internally, cancer in children are hereditary and genetically determined. Understanding the burden of cancer among children, its age-related trends, and the potential for international cooperation is an important starting point for cancer control programs. The purpose of this study is to analyze the incidence of malignant neoplasm in the younger group of children in the Kyrgyz Republic. Material and methods of the study. All data were taken from the hospital oncology register of the National Center of Oncology and Hematology of the Ministry of Health of the Kyrgyz Republic. In total, during the period from cases in malignant neoplasms in children aged 4 years were registered among boys and girls in the cities and regions of the country. Crude, intensive, and standardized incidence rates were calculated with confidence interval and using the world standard population data on the average annual number of the children in the Republic were used from the National Statistical Committee. The current char, char, characteristics of the average annual incidence of the cancer in children in Kyrgyzstan were analyzed by gender, age 4 years, ethnic group, and types of cancer. All types of cancer were classified according to the International Classification of Childhood Cancer. Key indicators Kazakhstan, Uzbekistan, Tajikistan, Turkmenistan, Kyrgyzstan. Total population born per year, annual number under 5 deaths thousand GNE per capita population 1,000 under 11 years of age. Annual population growth. The main parameters of pediatric cancer service countries: Kazakhstan, Uzbekistan, Kyrgyzstan, Turkmenistan, Tajikistan. Morphology, identifications by inspections, complete the treatment, surgery, RT, CT, pediatric oncology in Kyrgyzstan, National Oncology Center, Bishkek, 17 beds Bishkek, 11 beds in Osh, and for radiation therapy for children, National Center of Maternity, Osh Pediatric Hospital, 18 beds in Osh. The structure of oncological morbidity in children. Gepard, otter, testis, ovary, soft tissue, bone, kidney, neuroblastoma, brain, leukemias, Hodgkin's, non-Hodgkin's lymphoma, retinoblastoma, liver, gonads, soft tissue, bone, kidney, neuroblastoma, brain, Hodgkin lymphoma, non-Hodgkin lymphoma, leukemias. This standardized morbidity rates for children with asked by gender in the younger group 4 years per 1 million children. Leukemias, HL, NHL, brain, neuroblastoma, Wilms, bone, soft tissue, ovary, testis, retinoblastoma, hepatoblastoma, total. Incidence of ZNO in young children by ethnic group. Kyrgyz, Uzbek, Russian, Oza. Crude number of patents and age standardized incidence rates of malignant tumors in rural and urban populations. Uh,
2008 to 2020.
Leukemias, HL, NHL, brain, neuroblastoma, Wilms, bone, osteophyte, eurytestis, ovaritestis, retinoblastoma, hepatoblastoma. In total, Urnan village, ACR, geographical variability of the cancer of young geographical variability of the cancer of your young children. Kazakhstan, Kazakhstan, China, Tajikistan, Batken, Osh, conclusions in the Kyrgyz Republic, the incidence of malignant neoplasms in the younger age group of children is low compared to the developed countries of the world, but it is comparable with the indicators recorded for developing countries. In the structure of neoplasms, the leading types of cancer we acute leukemia, kidney tumors, retinoblastoma, soft tissue tumors, and neuroblastomas. There was geographical, ethnic, and gender and age related variability in the spread of malignancies in the republic. There is a certain in under underestimations in the registration of cases of acute respiratory viral infections in young children. This reduce for the improvement of the pediatric oncology service in the country. The findings may determine for future priorities for public health and scientific research. Dear Makimbetov Emil Kojoshevich, on behalf of Times scientific group, we are delighted to welcome you participate as a speaker at our esteemed third European Summit on Cancer Research and Oncology, which is going to be held during September. Berlin, Germany. Theme, thank you. Welcome to Kyrgyzstan.
Okay. Hello to everyone. I am Dr. Tuba Khan and I am working as a senior medical officer in DUHS. So today I am presenting my research, and the title of the research is Validity of the F18 FDG-PET CT in the detection of bone marrow disease in Hodgkin's and non-Hodgkin's lymphoma. So we start with the introduction. The PET with FDG-PET CT is useful for diagnosing the lymphoma, include Hodgkin's and non-Hodgkin's both. It has the ability to detect the bone marrow involvement, which is comparable with the biopsy. The traditional bone marrow biopsy has been the gold standard for diagnosing lymphoma. On the other hand, the FDG-PET CT provides functional and anatomical data without any surgical intervention. Next. Okay, so objective to determine the validity of F18 FDG PET CT in detection of bone marrow disease in Hodgkin's and non-Hodgkin's lymphoma, taking bone marrow biopsy as the gold standard. Next. Study design. Okay, so this is a cross-sectional study which is conducted in the Nuclear Medicine Department, Kiran Hospital, in a duration of 6 months, January 21 till 30th of July 2023. Okay, sample size total 87 patients with suspected lymphoma are included in the study, and the age of the patients are between 18 and 70 years. 18 and 70 years. Okay, so the sampling is non-probability consecutive sampling. The inclusion criteria is biopsy-proven Hodgkin's and non-Hodgkin's lymphoma between the age 18 to 70 years and either gender, male or female. The exclusion criteria, if the patient has received any prior treatment, and the interval between the PET CT and the biopsy is more than 2 weeks. Data collection. Okay, so I took the ethical approval from the committee CPSP, and the PET CT protocol we use the radiotracer F18 FDG, and the dose is between 150 to 250 MBq IV. Fasting of 4 to 6 hours required, and the glucose level should be under less than 150 milligram per deciliter. The scanner is used Siemens Biograph LSO PET CT, the acquisition 60 minutes post-injection acquisition done from head to mid-thigh. CT is used for attenuation correction and anatomical localization. The reconstruction is done on 3D RAMLA algorithm. The bone marrow biopsy is taken from the iliac crest aspirate plus fine biopsy. The staining is H&E reticulin. The markers IHC CD3, CD20, CD15, CD30, CD45. Interpretation. The interpretation, the abnormal uptake, we call the abnormal uptake if it is more than the liver uptake of the PET CT positive patient, or there is any focal or diffuse tracer uptake in bone or bone marrow. Data analysis, the software used is SPSS version 21 quantitative data, the mean plus minus standard deviation or median qualitative data in percentage. Diagnostic metrics are sensitivity, specificity, positive and negative predictive value, accuracy. The effect modifiers are age, gender, symptoms, hemoglobin level, WBC levels, platelets, and LDH, lactate dehydrogenase level. So this is the gender distribution pie chart in which we can see that the male are 63.2%, while the females are only 36.8%. And if we see the chart, the bar chart of the clinical symptoms, we include the fever, weight loss, and night sweats. And among all the weight loss patients, the patients who are having a weight loss is more than as compared to fever and night sweat respectively. If we see the bar chart of PET versus biopsy detection, the PET is positive among more than 35% of patients, and the biopsy is positive in 25% of the patients. The results in the gender distribution, 55 people were classified as male, while 32 were classified as female, as I shown you in the figure 1. The fever was observed in 40.2% of the patient, totaling 35 individuals as shown in figure 2. The drenching sweats were documented in 31% of the patient population, affecting a total of 27 individuals as shown in the figure 2. The weight loss was noted in 37 patients, 42.5% of individuals as shown in figure 2. On F18 FDG PET CT finding, bone marrow disease was noted in 38 patients as shown in figure 3. Bone marrow diseases was detected in 28.7% of the patient based on biopsy as gold standard as shown in figure 3. In our study, the diagnostic accuracy of F18 FDG-PET CT finding was 80.46% in diagnosis of bone marrow disease with sensitivity of 92%, which is quite high. The specificity is 75.8% with positive predictive value 60.53, and again the negative predictive value was very high, that is 95.92% by using bone marrow biopsy as gold standard. Several studies have reported sensitivity ranging between 31 and 68%, while in another study conducted on 142 patients, PET identified a high number of nodal areas in 32%. In a study by Mazahir S. et al., the sensitivity of FDG PET CT was 100%, specificity was 76.57%, NPV was 76.5 and PPV was 29.72 and diagnostic accuracy was 78.62. If I conclude my study, it is to be concluded that the F18 FDG PET CT holds potential for identifying bone marrow pathology in both Hodgkin's and non-Hodgkin's lymphoma. The results suggest that there is a promising ability to accurately detect patients with or without bone marrow involvement, which makes it a helpful method for assessing the condition and planning treatment without the need of intrusive procedures. These are my references. Thank you so much.
I want to present these concepts of using a simple cytomorphological biomarker for HPV detection or risk assessment. From cytology to biology, referencing. I am Asma Extension University. I want to make you remember that HPV 16 and 18 is responsible of 70% of all cancers worldwide, and HPV has cytomorphological changes all appear here in this picture. All these cytomorphological changes induced by HPV infection, and they can be used for the diagnosis of this virus, which is really a danger virus. Some of these criteria are classical for diagnosis, and some of them are non-classical. I do previous study on master and PhD, and I found the correlation between binucleation and the molecular biomarker of HPV. Then this was the main result of my previous study, which made me to initiate this review article about the importance of binucleation and the uses of them in grading of cases of cervical cancer, cases of pap smear for prevention of cervical cancer. In this result, I found the virus harbor in 72% of women attending the clinic of gynecological. And this is what type 16 and 18 specifically. We can go to the next. We can simply define binucleation as presence of two nuclei within a single cytoplasm is increasing recognized as more than non-specific cytological feature, although it can occur under physiological reactive conditions. Many many cases we can find binucleate cell. The presence of them in cervical epithelial, particularly in the context of reflects underlying mitotic disruption and genomic stability. Denucleation as significance of nuclear mitosis and nuclear disturbance. Here, how the difference between a normal cell and binucleated cell. It's called kissing nuclei. The nuclei are overlapped. They are not really two nuclei. They really bilobulation. That was what happened in the cell in case of HPV infection. It's simple to be glanced while you are reading the smear. A binuclei is abnormal cell. Okay, the next. Binucleation may lead to many consequences: senescence or mitosis, or mitosis disturbance, or aneuploidy. Okay, next. Here we this diagram appears the pathological process how binucleate cell come on. Okay, we can go to the next slide. We glanced at binucleate cell according to HPV infection. It's not really a binuclei, it's bilobulation. And it's go greatly to B16 accumulation and B21 and senescence appearance of in cells. And gradually for multi nucleation or micronuclei formation. Okay, we can go to the next. Study binucleation is stress and to establish an integrated molecular thinking the binucleation is senescence expression nuclei formation. Okay, next. Key feature of the binucleation biological model stratification.
Hello, Dr. Asma. Hello.
Yes.
Dr. Asma,
Yes, I am with you.
we are not able to hear you properly.
You
Hello?
can't hear me?
Yes.
Yes.
During presentation, we can't
You
able
can't
to.
hear?
Now we can hear you. Hello?
Yes, I am with you.
Yeah, you can proceed with the presentation now. Okay.
Yes. Okay, this was a heavy review article done to find the association between the many phenomena accumulate with binucleation and after it, and how to use them for risk stratification of cases. Okay, next slide. Okay, this is the infographic extract of this presentation. Next slide. The result high risk HPV cell cycle regulation through E6 and E7 point failure, autosomal abnormalities, defective cytokines resulting in manipulation of early structure manifestation of mitotic failure. It's an early manifestation of mitotic failure. It's the first result. Okay, the next slide. Please, next slide. Binucleation may precede classical cytopathic features such as colocynthis and can be detected even in negative intraepithelial lesion cases where it functions as an early biological signal, while in ASCAS it is reinforces diagnostic interpretation. Go to next slide. Binucleation is further associated with cellular senescence and B16-INK4A overexpression, linking morphology with molecular dysregulation as a dynamic intermediate state. Binucleated cell may undergo senescence, apoptosis, mitotic catastrophe, or progress toward genomic instability. As appear in this diagram, how HPV-driven oncogenesis lead to oncogenic transformation. Then senescence and binucleation is happen. Then binucleation compression model is highly selected for HPV infection. The presence of micronuclei also reflects chromosomal misaggregation. The next slide. The presence of micronuclei reflects chromosomal misaggregation and downstream DNA damage, and their coexistence with binucleation indicates compound mitotic dysfunction and increased progression risk. So the concept of this review article that we can gather these two phenomena together to risk stratification of any cervical smear, even if there is no change of oncogenic change is there. Next slide. The conclusion that binucleation should be interpreted not merely as cytological feature, but as graded biological biomarker reflecting HPV-driven oncogenic stress, senescence-associated dysfunction, and genomic instability. The integration of binucleation, compression, and micronuclei and B16 INK4 expression provides a robust framework for early detection, biological grading, and risk stratification. Here, the proposed scoring system. When you screen the cervical cytology smear, the next slide, if you found just only binuclei cell, you can give a score 0 to 2, and this mean early mitotic dysfunction. In the next level, if you found with binucleation and nuclear ATBL, the smear get 3 from 0 to 3, cytological, it's mean cytological abnormality. If you found binucleation compression, which we expressed before by kissing nuclei, and appear in the first of this presentation, the kissing nuclei mean there is a binucleation compression. We give the score to 3, and this is mean there is a mechanical and oncogenic stress on this smear. If we found or read chromatin abnormalities, it could score 0 to 2, and it mean nuclear instability. If we found in immunostain B16 INK4 expression, we give from 0 to 2, it's mean HPV-driven oncogenic signaling. If we found the micronuclei with them, it's mean there is chromosomal misaggregation and genomic instability. Then we collect the numbers and found the total score is 14. In cervical cytology, next slide. In cervical cytology, binucleation may range from a benign, adaptive, or reactive phenomena to marker of significant HPV-driven oncogenic stress. A stratified interpretation of binucleation is biologically and diagnostically necessary, as not all binucleated cells carry the same significance. At the lowest level, binucleation may occur as a physiological or reactive phenomena without oncogenic implication. At an intermediate level, it may reflect early HPV-induced mitotic dysregulation, particularly in NILM smears where classical cytopathic fissure are absent. At a higher level, binucleation accompanied by nuclear ATP and compression suggests increased genomic instability and stronger oncogenic stress, especially in association with high-risk HPV infection. When combined with P16 overexpression, binucleation may serve as a cytomorphological surrogate of biological active HPV-driven transformation. This stratified model allows binucleation to be interpreted as not as binary finding, but as graded morphological marker reflecting the biological spectrum from benign cellular adaptation to oncogenic progression. Okay, the next slide shows the stratified biological diagnostic model of binucleation in HPV-associated cervical cytology. It's begin from physiological benign binucleation to level 2 reactive inflammatory to level 3 early HPV-associated NILM, in level 4 oncogenic ASCUS early SIL, and level 5 level benign begins benign physiology. In level 5, we found B16 expression, and then micronuclei where and multinucleation will appear. Okay, next slide, integrated scoring system for binucleation compression and B16. If we found score from 0 to 4, it's low biological significance. From 5 to 8, early HPV-associated activity. 9 to 11, oncogenic binucleation. 12 to 14 in the score, high oncogenic stress. Okay, we can go to the next slide. Integrated binucleation compression micronuclei and B16. Here we found that binucleation in NILM and in ASCUS and LSIL or higher. Okay, we can go to the risk stratification in the next slide. From 0, next slide, from 0, 4, the risk stratification, low biological. From 5 to 8, early HPV associated activity. From 9 to 11, oncogenic binucleation. From 12 to 14, high oncogenic stress. Its binucleation is really indicate the increasing risk of progression when glanced and precisely interpreted. What is the clinical impact of this model? It's enhanced early. The next slide, please. The clinical impact of risk stratification model built on binucleation and micronuclei and B16 and nuclear and binuclear compression. It's enhanced early detection, including NILM, improves diagnostic specifically, especially with compression and micronuclei, risk stratification for better clinical and decision making, cost-effective approach for resources in limiting settings. The key message of this presentation, binucleation is not a non-specific finding, but a graded biomarker of HPV-driven mitotic dysfunction. When evaluated with compression, micronuclei, and B16 expression, it provides a powerful biologically informed tool for assessing infection intensity and progression risk. Next slide. Implementation of the proposed scoring system and diagnostic model may enhance clinical decision-making, particularly in resources limited setting, and warranty further validation in perspective. Okay, thanks for you. She's a promising plant, Fagonia, and I am really I have used artificial intelligence to find this model, and I'm thank OpenAI AI company. Thank you all. Now the floor is open for questions.
Available webinar. My name is Ahmed Ghadi Sabbar from Iraq Middle Technical University College of Health and Medical Technology, Assistant Professor in Pharmacological Biochemistry. I hope my presentation will be informative and interesting for the audience. Thank you for all your attention. And now I will begin my presentation. Please hear me?
Yeah, we can see the slides, doctor.
Okay.
You can change it to the presentation mode and you can start your presentation.
Okay, now I start to my presentation. The address of my research called Synergistic Anticancer and Certain Biochemical Events Impact Estrogen Positive MCF-7 Breast Cancer Cell Line by Local Citrullus colocynthis-lemon fruit hydroethanolic extract combination.
Hello, Dr. Ahmad.
Okay, now introduction and research background. The global burden of cancer has increased significantly, leading to substantial psychological, physical, and economic pressure on patient, community, and health system. Many health systems in different countries have limited capacities. Many such burden and huge number of cancer patients around the world don't receive proper diagnosis of
Dr. Ahmad, sorry for the interruption. We can't. Hello, Dr. Ahmad.
hello.
Sorry for the interruption. We can't able to see the slides moving, so we will share on your behalf.
Yes.
Okay.
Okay.
Is
Next
the slides
slide.
visible, doctor?
Next slide. Okay. Next slide.
Give us a moment, doctor.
Okay. Next slide. Okay. Background and significance. The global burden of cancer has increased significantly, leading to substantial psychological, physical, and economic pressure on patient, community, and health system. Many health systems in different countries have a limited capacity to manage such a burden, and huge number of cancer patients around the world don't receive proper diagnosis or access to high-quality medication in timely manner. Tumor can arise from virtually any cell types or tissue in the body, which means that cancer can involve all organ system and cell type. Although some tissue are more susceptible than others and is therefore inherently more complicated than other major disease. Next slide. Research objective. The aim of the study was to evaluate the anti-cancer potential of a herbal combination of Citrullus, colocynthis, and lemon fruit by using different approach, focusing on synergistic effect against estrogen-positive MCF-7 breast cancer cell line. Next slide. Material and methods. Next slide. Herbal combination preparation. One fresh local Citrullus consists bulb of 100 grams was pulverized with 50 grams of lemon fruit bulb using a blender. The mixture was then macerated for 48 hours in hydroethanolic solvent 50-50 at 40 centigrade in shaking water bath. It was then filtered first through gauze and secondly through a millipore filter 0.22 micrometer per size. Serial dilution of 150, 25, 12.5, 6.2, and 33.1 microgram per ml were prepared using deionized water. Next slide. Maintenance of cell culture. MIM was used to maintain MCF-7 cancer cell line supplement with 10% calf serum, antibiotic including penicillin, 100 units per ml, and streptomycin 100 microgram per ml were added. Trypsin EDTA was used for passaging cells, which were reseeded at 50 confluents twice a week and then incubate at 37 centigrade. The MCF-7 human breast adenocarcinoma cell line was obtained from American type culture collection, where it underwent authentication and quality control. Upon received cells were handled, cultured, and stored in accordance with the ATCC standardized protocol to ensure their identity, viability, and contamination-free condition. Next slide. Cytotoxicity assay. A cell viability assay using MTT was carried out on 96 well microplate. MCF cell was cultivated at 1/10⁴ cell well. After 24 hours or once confluent monolayer was reached, cells were exposed to hydroethanolic extract of herbal combination. Cell viability was assessed after 72 hours of exposure by discarding the medium and adding 28 microliter of MTT solution, 2 milligram per ml. The cells were incubated for about 1.5 hours at 37 centigrade. After incubation, the MTT solution was discarded and formalin crystal remaining in the well were dissolved by adding 130 microliter of dimethyl sulfoxide, followed by incubation and at 37 cells for 15 minutes with shaking. The cell viability were calculating depend of the following equations. Next slide. Apoptosis estimation event. Acridine orange propidium iodide assay. A total of 7,000 cell well were cultivated in a plate. Cells were exposed to the herbal extract at the IC50 concentration and incubated at 37 centigrade. For dual staining, 50 microliter of acridine orange propidium iodide stain mixture were added to well at 25 centigrade for 30 seconds. After that, the stain was removed and Leica fluorescent microscope was used to capture image. Next slide. Neuropeptide receptor, MPY-R1 and MPY-R5 station. Both human neuropeptide receptors Y5 and Y1 were estimated using a standard enzyme immunoassay, sandwich enzyme immunoassay, ELISA kit of company MyBiosource. The standard test sample Citrullus, colocynthis, and lemon fruit combination extract were added to the well subsequently. MPY-R5 and MPY-R1 were measured depending on the protocol of the company manufactured. The standard curve was generated based on the experiment. The cell culture supernatant was centrifuged for 20 minutes to discard insoluble impurity at 1,000 by gram at 2 to 8 centigrade, and the clear supernatant was then collected and say was done immediately. Next slide. Cytotoxicity and apoptosis analysis results. Cytotoxic effect. The cytotoxic effect of different concentration of ultrafiltrated crude, Citrullus, colocynthis, and lemon fruit hydroethanolic extract of herbal combination on estrogen positive MCF-7 breast cancer cell line at one exposure time 72 hours was examined. All concentrations of the crude extract inhibit the viability of this type of cancer cell line with highly significant difference at p value less than 0.05. The inhibition was in different degree depending on the concentration of extract. However, a lower concentration of crude juice, 3.1 microgram per ml, achieved less anti-proliferative activity on MCF-7 cancer cell line. Additionally, the IC50 value slightly exceed 100, just 100.3. Next slide. Apoptotic event. The cytogenic degradation event due to apoptosis were labeled by propidium iodide acridine orange assay using Leica fluorescent microscope, which showed a highly significant difference between a treated and control group of MCF-7 breast cancer cell line. From this graph, the treated cell showed an orange fluorescent by propidium iodide acridine orange staining and gathered in concentration and located in bias pattern. Next slide. Neuropeptide receptor modulation. Neuropeptide Y receptor inhibition. Additionally, the antagonistic effect of hydroethanolic extract of the herbal combination on neuropeptide Y receptor R1 and R5 were truly assessed. The potency and effectiveness of this formulation were confirmed by data showing statistically significant dose-dependent inhibition of MPYR1 and MPIR5 activity as a concentration of the herbal combination were gradually increased. Next slide. Discussion and mechanistic interpretation. Synergistic cytotoxic action, enhanced therapeutic efficacy. The combination or the combined hydroethanolic extract of Citrullus, colocynthis, and lemon fruit exhibit high efficiency as a cytotoxic agent. The synergistic effect between the two herbs enhanced apoptosis induction beyond that single extract could achieve. Compared to untreated MCF-7 cell, the treated group showed significant reduced viability and increased DNA fragmentation. This validates the hypothesis that the specific herbal combination can reinforce therapeutic efficacy through synergism. Next slide. Role of neuropeptide Y receptors. In variety of cancer models, most notably breast carcinoma, MPYR1 and MPIR2 receptors are both well characterized facilitators of oncogenic metabolic pathway that play a major role in tumor growth, survival, and potential for metastasis. Specifically, MPYR5 has been linked to paracrine-mediated release of vascular endothelial growth factor and its upregulation, which in turn promote angiogenesis. Neuropeptide Y, which is primarily expressed in the breast tumor microenvironment, exert its effectiveness through G protein coupled receptors. Among the receptor subtype MPYR1 and MPYR5 have the highest relative expression. Dense sympathetic innervation and correspondingly high MPY level define the breast tissue niche, which together create an ideal environment for aberrant signaling via these pathways. Targeting MPYR subtypes, especially MPYR1 and MPIR5, has therefore become a viable therapeutic approach for the treatment of breast cancer, despite the limited clinical translation of MPYR5 specific inhibitory modality to date. Recent research supports pathogenic role of MPYR5 in tumors and metastasis. The good news, the herbal combination have different types of bioactive compounds shared in part for cytotoxic effect against MCF-7 cell lines. From this event, apoptosis induction, antioxidant activity, suppression of some pathways, and metastatic activity, anti-metastatic activity. Present of different types of compound like terpenol and colocynthis, and also other antioxidant in the colocynthis, Citrullus colocynthis may share in the anti-cancer activity of this herbal combination. Next slide. By the other hand, the bioactive compound in lemon may share in part in antioxidant potential to eradicate the cancer cells due to consist of flavonoid, vitamin C, citric acid, and terpenoid group, which in turn, for when combination with colocynthis-lemon may synergize the potential activity as an anti-cancer agent. Next slide. Conclusion and future implication. Based on the experimental finding, the combination of these herbal extracts demonstrate considerable promise as a potential therapeutic strategy for breast cancer. The data indicate that this blend extract exert synergistic cytotoxic and anti-cancer effect against MCF-7 cell line, at least in part through the downregulation of neuropeptide MPYR1 and R5. It can be concluded that the Citrullus, colocynthis, and lemon juice combination extract show a high efficiency as a cytotoxic agent against MCF-7 cancer cell line. Thank you very much for your attention. Any questions? Any questions, please? Thank you very much.
Hello, everyone. I'm happy to be here and present our recent publication on acute leukemia. So, mortality analysis in Armenian cohort. So let's start. This is the publication that we published in the eCancer journal in 2025, and all the information regarding the acute leukemia research were including only the recent 5 years from 2016 until 2020. And we collaborated with Immuno-Oncology Research Institute and the Medical University of Armenia. So here, the definition of acute leukemias are a group of heterogeneous malignancies which are characterized by chronic hematopoietic progenitor cell proliferation. And if we speak about the incidence and prevalence of the disease, it's about 1.78 per 100,000 people who are younger than 65 years old for AML, about 16.8 in 100,000 people in older patients in the USA. For ALL, acute lymphoblastic leukemia, it's a higher incidence in childhood, since we know that ALL is about 90% of a childhood hematologic malignancies, with an age-adjusted rate of 1.5 per 100,000 people in the USA. Historically, acute leukemia had a very poor prognosis in the absence of chemotherapy, and the life expectancy was about 2 to 6 weeks. And currently, it has improved the outcomes. For ALL, the 5-year-old overall survival for pediatric patients is reaching 90%, and for adults from 47 to 55, because for adults there are still a lot of challenges. For AML, the 5-year overall survival for the younger than 45 years old is about 50%, and it is diminishes to the mere 2% in older than 75 years old worldwide. So here I wanted to highlight that Armenia actually is already an upper middle income country. However, with medicine and especially in oncology, the budgeting is still lacking, and we have a lot of complications related with financial toxicity. So we are considering ourselves with the low-income countries or middle-income countries, and we are comparing our data with these countries more than the high-impact countries. So we have the data that approximately 70% of all cancer-related deaths occur in low and middle-income countries, and this is where we see us. And the developed regions allocate 5 to 10 times per capita resources for cancer control compared to their counterparts in low and middle income countries. This is a known thing. And importantly, the financial gap between developed and developing nations is in context of widening. So it's expanding, it's becoming more and more. I have to say that with this kind of data analysis, we are calling for transparency because this is, as we see, is a first step to the solutions. So the aim of our research paper, I'm now presenting the manuscript that we typed. The aims included presenting the comprehensive assessment of the leukemia landscape in Armenia, highlighting the substantial disparities that profoundly affect treatment outcomes and thus to contribute to the development of the holistic strategies aimed at ensuring equitable access to appropriate care for individuals, irrespective of their socioeconomic status. For this, I have to call on attention that Armenia has only one hematology center, and we didn't have electronic database until we started to collect it on our own. So it was a little bit of a challenge to include all the patients with a certain diseases. But in this, that I was working in the center, which is the sole center of hematologic malignancies in all Armenia, gave us opportunity to collect our data and to present it equal for all the country, because as I mentioned, it was the only center where all the patients were gathering together. For the materials and methods, we did the retrospective analysis because we include the mortality cases. 431 acute leukemia patients diagnosed from 2016 to 2020 in Armenia were included. Death dates were taken from the electronic healthcare system of Armenia, which is already implemented from 2024, about 2024. And survival analysis was performed through the Kaplan-Meier method by our statistician. The results you see here, among 431 patients, so I included the paper archive because this is one of the complications that we had really all the data and not all the data was available. The complete data we could collect only from 245 patients, and anyway, by collecting all the data from also whatever we had of our paper archives, we calculated that dead patients were almost 72% of all the acute leukemia cases in our cohort, which is a very high case report, mortality case report percentage. The distribution of these mortality cases were 158, 65% for AML, 56, 23% for acute lymphoblastic leukemia, 2, which is a 1% of mixed phenotype, 28%, which is 11% of all AR unspecified cases. Here I have to mention that the unspecified cases was not only including the cases which were not diagnosed because of some financial toxicity or other reasons, but also the cases which occurred in hematology center with an emergency reasons. And then we had the patient with blastosis, for example, in CBC, and the patient died really fast and we couldn't collect all the data. So this is how we also have the unspecified cases of acute leukemia. So they are kind of half-diagnosed cases because of faster death. And median age was calculated 59 years old with a range of 18 to 85. We didn't include pediatric patients in this cohort, of which 112 patients, 46% of the cohort were female patients. Here you see all the data of the characteristics of these patients, and yeah, the CBC results and so on. So 24% of the cases, 58 patients died before the frontline chemotherapy. refused treatment. The cases in which we had refusal were 45%, which is 26 patients. Complete response with chemotherapy reached 34% of patients, 82. 21% of those patients died during the first remission. Primary resistance to chemotherapy were 30 patients. In 10%, it was not possible to evaluate treatment response because of empty bone marrow or other tests that there were not showing any kind of results, and we were struggling also about the genetic test to assess MRI and so on. So it was impossible because of diagnostic problems. And the 5-year overall survival we calculated for all the acute leukemia cohort, 22%. Here are the causes of the death. The main cause for the death were due to the disease progression, and the other percentages included other reasons like death before chemotherapy, including those refusing chemotherapy, early death within 30 days of diagnosis after starting induction therapy, deaths during remission, and deaths during unknown causes. Yeah. So, related to acute myeloblastic leukemia, we have several challenges in Armenia, some of which were partially solved. The statistic challenges include lower incidence, since we are assuming that the incidence could be higher, comparing our data with other countries and comparing our data also with developed countries, because we assume that the primary diagnosis in Europe and in USA is better than in low-income countries. So we assume that it has to be higher, and we compare it to 1 and 9 cases per 100,000 patients, which has to be 3 to 20 for AML in Europe and the USA. And the prevalence, as you see, is also kind of twice, no, not twice, but less compared to other countries. And we have also diagnostic challenges. Before 2010, the diagnosis of acute leukemia was based on bone marrow cytochemistry. This was not included in our cohort, these patients. However, we can say that this is a huge achievement that since 2010, we could have the flow cytometry and immunophenotyping. But yet it was not covered by the government. So we had problems also for the patients who could afford this very essential test for the diagnosis, so because they were paying for their own. And in our cohort, out of 158 AML cases, 135 were diagnosed with immunophenotypic. And as you see, still 23 patients couldn't afford it or for some reason didn't perform. Cytogenetic methods, only 37% of patients due to the high cost, because we here had the same problem. It was not covered by the government. Before 2026 January, we were having partially covered cancer treatment in Armenia, because government was paying for partially for the medication and for partially for the diagnosis and admission. However, some tests and some lab tests were not that much available for all the patients, and they were costing high. And for example, if the median salary in Armenia is about 500 euro, these tests were costing 200, 300 euro locally, and so for the patients were problematic to do. And this kind of limited access gave us not that much opportunities to do also the genetic tests. And you all know how FLT3 and IDH assessment has an important role in the treatment of acute leukemia and how they impact the results. And we think that the results of the high mortality and also the less overall survival is also related with this kind of constraints that we were facing. So the treatment challenges, the first standard induction for us was 7+3 regimen, which is also standard in, in USA and in European countries, it's not performed. Not largely performed. The consolidation therapy was either 3-4 courses of high-dose cytarabine or 7+3 again, but the preference was about high-dose cytarabine. Those who couldn't afford it, because with high-dose cytarabine, the medication costs were partially relied on the patient. 7+3 was more affordable, and that was the reason of the choice for the consolidation therapy with 7+3. The maintenance we were doing with cytarabine and 6-mercaptopurine regimen, 5+5, every 6 weeks for 2 years. The choice of treatment strategy often depends on the patient's socioeconomic status, given that chemotherapy is only partially covered by the state. Induction therapy with 7+3 were performed in 32%, consolidation with HIDAC 29%, consolidation with 7+3, 71% of the cases. Low-dose cytarabine were received few patients, which were in mostly older patients, our geriatric patients who were having few comorbidities, a few other diseases which were not letting them to receive the heavy chemotherapy, intravenous chemotherapy, so they were receiving low doses of cytarabine, and it was only 6% of this cohort, and other regimen kind of 21% of all the cases. No targeted therapy was performed by that time. And you all know that with this midostaurin, gilteritinib, and so on, we have increased overall survival in acute leukemia treatment. And it was highly important to give access to the patients to these medications. So the patients all were informed about the possible treatment with such agents. However, none of them could afford it, and they were not provided locally. So, as you see here, is depicted the management and outcomes of AML with the treatment. So whatever we already said. And the complete response was still reached in some portion of the patients, of which vast majority relapsed, and few reached second complete remission. So acute lymphoblastic leukemia challenges in Armenia is still statistical, diagnostic, and treatment related. For the statistical options, I also highlight the lower incidence. As of we expected to see it higher, it's only 0.68 per 100,000 cases. Diagnostic challenges include the genetic performances, and because we have genetic tests not fully available, and immunophenotypic is in most of the cases were performed, however in all the cases almost not covered. And we could also access Philadelphia chromosome. We are receiving with Max Foundation the PCR kits for Philadelphia chromosome detection. However, as you know, for ALL primary diagnosis, FISH is indicated, and for this reason, it was also not covered and not provided. So 59% of patients could perform it on their own. Treatment challenges were the availability of some drugs which are included in the mentioned chemotherapies. The main protocols were chosen as GMOL. As you know, this is the main protocol currently used worldwide. In most of the cases, 23% of patients received GMOL with 85% receiving complete remission. Others received older version of the same protocol, of which 58% 58% achieved complete remission. For young adults, we used BFM because of the current recommendations that they are treated more as a pediatric patients, and of 13% of those patients received this protocol, of which 86% achieved CR, 13% CALGB chemotherapy, of which 86% achieved CR, and 11% received other regimens, and the CR was achieved in 50% of the cases. 59% of patients experienced relapse, and only 50% of them received relapse therapy, with none achieving a second remission in ALL cohort. High costs of drug that are not covered by the state were the main challenges of the cohort, of which pega asparaginase, there is a high doses of pega asparaginase in the GMOL regimen, and it is highly related to the treatment response. Rituximab, in some cases, when we have CD20 positive status, nelarabine were totally not affordable for our patients, leading to some receiving treatment without those critical components. In the case of Philadelphia positive ALL patients, all the tyrosine kinase inhibitors were available due to Max Foundation, so we could provide them with all the required tyrosine kinase inhibitors. Blinatumomab, inotuzumab, ozagamicin, and CAR-T therapy was not available. We have some cases currently of blinatumomab in adult and few cases in pediatric patients. All were funded with humanitarian aid, however, were not provided locally, and by that time, from the mission period, it was not at all practiced. The 5-year overall survival in Armenia was evaluated at 26%, which is visibly lower than in other countries. Here we see the problems with equipment, with treatment access, and thus we have the study limitation, the potential bias for the study. The dataset does not account for possible cases of AL that remain undiagnosed, particularly in less accessible regions of the country. Our findings therefore provide an essential, albeit incomplete, perspective on the mortality of AL in Armenia. This we say just because of the lower incidence and prevalence that we expect to be higher, however, it is not detected. In a conclusion, the limited availability of modern diagnostic and treatment modalities in Armenia has resulted in inferior outcomes of AL, with a lower median overall survival compared with the developed world. And with addressing this, we have hoped to contribute to the development of these problems. However, I want shortly to describe you also our next findings. As you remember, probably we had about 72% of mortality cases, but we published also data for the next 5 years already. You can read it in Hemasphere. We published this abstract for the European Hematology Association annual meeting, and we analyzed the next 5-year mortality data on our acute leukemia cohort. And here I want to describe you shorter what we find out. So we wanted to report all the cases of mortality of acute leukemia in Armenia and to support local treatment policy development. We took the patients from 2016 to 2020 cohort already, 5 years. We compared this existing previous data of 2016 to 2020 cohort to the current data, which we took from 2021 January until December 31st, 2025. So the last 5 years. And we overall had 480 adult patients, among which all of the data was already available because we didn't have any problems with the paper archive. The number of dead patients was calculated 224, of which female patients were 106. Median age was 64. The CFR was 46 to 7%. case fatality rate for acute leukemia, of which case fatality rate was calculated for AML as 168 cases, for ALL 39, and 22 for undifferentiated cases. Complete morphological remission after first-line therapy were reached to 65% of the cases, which is 27 to 2% ALL. And for AML 41, of whom 44 subsequently relapsed. Median time from diagnosis to that was 118 days. The mortality comparison for Armenia reached some kind of improvements. The cases of the mortality were lower compared to the previous 5 years. The initial therapy, the data before initial therapy was achieved in 61 people, which is 27 to 2% of all the cases due to critical condition treatment refusal, mainly for the financial or psychological reasons. And death within 30 days were calculated in 55% and within 90 days to 95%. The leading causes for death were disease progression again here, infection, sepsis, pneumonia for 42 patients, septic shock 18, COVID 6, cerebrovascular events 8, thromboembolism 6, cardiac complications 12, renal failure, and so on. Here you see all the schematic results of our death causes for acute leukemia during 2021 and 25. And here, as you see, the leading cause of death was again disease progression. As a conclusion, we confirm that case mortality rate in general population was lower, and the case fatality rate among diagnosed adults was relatively high, reflecting the aggressive nature of AL despite its rarity, comparative rarity. Compared with the previous cohort, the improved outcomes with a decreased CFR was assessed during recent years in Armenia. The leading cause of death remains disease progression. Further local improvements in access to diagnosis, therapy, and supportive care are required. I have one really promising good news that from 2026 January in Armenia was implemented already the obligatory medical insurance, and in Armenia the government tries to cover almost all of pocket expenses of our patients, and we hope that with these analyses and with our further analysis we can support this implementation and to have a better future for our acute leukemia patients. These are my two references of our two publications that I presented to you. Thank you very much for your attention. In case you have questions, I will be really happy to answer those.